Hi class, welcome to week 2. As we move forward in class, we will explore the biochemical and physiological effects of a drug on a person's body. You will become familiarized with two specific keywords that I'd like you to remember. The first one is going to be pharmacodynamics, and the second one is going to be pharmacokinetics. But in this micro lecture, I want to talk to you about amitriptyline, also known as Elavil. Elavil is a tricyclic antidepressant, and this medication is normally prescribed within the range of 150 to 300 milligrams. A key point to remember is that sedation is high. Now, another key point to remember is that when seeing clients in the clinical setting, you must keep in mind that monoamine oxidase inhibitors with a tricyclic is safe, provided that the prescribing psychiatrist adds an MAOI to an established tricyclic regime. Now, other agents such as bupropion, Wellbutrin, or Lexapro are contraindicated, and they can cause a life-threatening event. And the reason why is because clients may develop a serotonin malignant syndrome when combining the medication with an MAOI, in other words, a monoamine oxidase inhibitor. Now, mirtazapine is a potent 5-HT3 blocker and thus acts as an anti-nausea agent. In fact, this antidepressant medication is prescribed in a range of 15 to 45 milligrams, and it is also known as Remeron in a clinical setting. Now, a key point to remember is that sedation is mild. Now, moreover, this medication antagonizes the central presynaptic alpha-2 adrenergic receptors, leading to increased release of serotonin and norepinephrine in the synaptic cleft. Mirtazapine is effective in the treatment of post-traumatic stress disorder. On this note, please remember that it is imperative to know that this antidepressant targets very specific areas in the brain. Neurotissue is also implicated in post-traumatic stress disorder. But to be more specific, the serotonergic brain circuit is affected. The hippocampus is also affected. The hippocampus is well known for transferring memory from short-term memory to long-term memory. The frontal lobe is also affected, and the frontal lobe, as you already know, is responsible for executive functioning. And then, of course, also the amygdala. The amygdala is also implicated in post-traumatic stress disorder because it is there where memories become embedded. Very specifically, memories of psychological trauma. Now, in terms of physical sequela, weight gain, it's a common side effect associated with mirtazapine. Moreover, other common side effects include dizziness, drowsiness, sedation, and also erectile dysfunction. Now, prazosin is commonly used in the treatment of nightmares associated with post-traumatic stress disorder. It is most notorious for producing a first dose phenomenon. It may cause idiosyncratic hypotensive response, which is a very rare but serious medical condition. Now, to avoid all this, prazosin is normally scheduled as a 1 milligram dose at bedtime for 3 consecutive nights. In subsequent titration, it's normally all the way up to 10 milligrams or more until nightmares are controlled and sleep is, of course, restored. Now, teaching military personnel stress management skills and also exposure strategies coupled with education could help prevent post-traumatic stress disorder. Now, the use of anti-anxiety medications, on the other hand, it's not recommended as a preventive measure for the treatment of post-traumatic stress disorder. Consider this. A 35-year-old man presents with a treatment refractory depression, and he has failed treatment with paroxetine, citalopram, bupropion, and lithium. Specifically, he had failed to respond to lithium augmentation. He refuses electric convulsive therapy. On reviewing his medical chart, the prescribing psychiatrist note that his hypertension is being treated with clonidine. Now, the patient that I just described has treatment-resistant depression. He has failed 2 SSRIs, and it would be reasonable to consider an SNRI, in other words, a serotonin norepinephrine reuptake inhibitor such as Effexor. In a clinical setting, this medication is prescribed in a range of 75 milligrams to 350 milligrams, and sedation is low. Now, current use of mirtazapine or nortriptyline in a patient that is taking clonidine may result in decreased antihypertensive effects, and an immediate referral to his primary treating physician or prescribing psychiatrist is in order. In your textbook, you will come across bipolar disorders. Now, in terms of treatment with pharma, please remember a steady state of lithium levels are attained after 2 days of constant dosing. Now, lithium levels are attained after 5 days of a dose adjustment, and of course, this needs to be done by the assigned prescribing psychiatrist, and of course, it is recommended to check the lithium levels 5 days after initiating lithium or after a dose change or titration. On this note, as a therapist, you must always assess the patient's compliance with medication regime, and as soon as feasible, refer the client to see his or her primary treating physician or the prescribing psychiatrist. Please remember that when dealing with geriatric population, elderly patients require more frequent monitoring. And also the levels of serum, they need to be checked because of several reasons. Their lithium levels tend to fluctuate even without any dose adjustments, and they are also more susceptible to lithium liver toxicity because of the low levels of serum. There are commercially available test kits that provide convenient and accurate measure of blood lithium levels in the office setting, but in your case, you would need to refer your client to see the prescribing psychiatrist as soon as feasible. It is important for all of you to make the proper referral, and when necessary, consult with the prescribing psychiatrist, provided that you have proper consent from your client. In this micro lecture, we discussed mirtazapine as an antidepressive medication and how this medication increases the release of serotonin and norepinephrine in the synapse cleft. Prazosin is the treatment of post-traumatic stress disorder, and the avoidance of using anti-anxiety medications to post-traumatic stress disorder was also addressed. Treatment resistance, depression, and prescription range was also noted in this lecture. We also addressed lithium salt and the medication of choice for bipolar 1. As always, I thank you for your attention, and I look forward to seeing you in week 3.